Good morning. So super excited to be here. Can everybody hear me? Yes, okay, I think you can hear me. Okay, great. So super excited to be here. A lot of energy here. I'm so happy that we're able to have this event here today. After the pandemic and not being in events, it feels really great, really exciting, a lot of energy here. We're gonna have time after the event for networking, so don't feel like we try to cut you short. We didn't want to cut you short from the event, but we did want to start on time and try to get you out on time and have the opportunity to network after the event. So feel free to do so and stay afterward and make connections. I mean, this is part of what we want to do here is present the content, but also have opportunity to connect with everybody, meet new folks. So my goal here is to meet someone new that I haven't met before and be able to have communications with you and about the work that we're doing and figure out how to partner with you. So that's part of my goal here today as well, and on top of the content. So right now I'd like to invite Dr. Rosa Gill to provide our opening remarks. Dr. Gill is a founder and president and CEO of Community Life, Inc., and also chair of the board of the Federal Reserve Bank of New York. So she's our boss.
So good morning. I hope everybody's doing well here, and I want to welcome you on behalf of the board of directors. Thank you so much for taking the time to join us in person today. And we are so grateful to have the distinguished panelists joining us here today as well. Thank you. We are bringing stakeholders together to highlight partnerships and investment at the nexus of health and housing. The New York Fed is very much committed to foster health in all neighborhoods and how residents can all contribute and benefit from the economy. There is no economic development without healthy communities, and I hope that we all understand that. The key to that are kids who grow up healthy, thinking they can be a doctor, an astronaut, an entrepreneur, an economist, even the president of the bank, the Federal Bank of New York, right? So, but those dreams need to be achieved with health and economic well-being. There can be nothing more important than creating an ecosystem that allows that to happen, to create community economic opportunities that yield healthy communities where to achieve those dreams, right? And there is natural alliance between people who work in health as well as those who work in housing. And poverty, we all know here, poverty and housing are major social determinants of health. And our objective today is to highlight how partnerships between healthcare systems and community economic development institutions are investing in affordable housing to improve health outcome and health equity. Sometimes, more often, but sometimes we work in silos. But our purpose today is to foster an understanding of the importance of partnership between healthcare system and community economic development organization to create a healthy communities, but we are going to do that together. I and my colleagues on the board of directors look forward to hearing new ideas, new partners, new resources, and new alliances that have the potential to reduce economic inequities and health disparity. Again, I thank you for being here today and enjoy the session.
Thank you, Rosa. Thank you very much. And why don't we have our first panel come up? It's just interesting you talk about keeping those dreams alive. My husband's a pediatrician, and he used to say how when patients would come in for like a well child check, He said, I didn't need to see the labs because I could just look into their eyes, and if they were bright, I knew what the labs would be, right? But there's a dulling that happens when people are having those dreams taken away from them, or their environments that are so stressful. And so that really is the sort of the idea here is all babies are born with bright eyes, and it's our job to keep them bright for a lifetime. And one way we do that is to make sure that they grow up in a neighborhood, in a house that is decent and safe and something they can be proud of. Rosa had a project that was just opening a couple weeks ago in the Bronx, and one of the tenants was the speaker at the ribbon cutting ceremony, and he was just grinning ear to ear. He's like, look, I get to live here. Can you believe that? And then he said, and I'm going to buy a mansion because I've got a good job, I'm going to get a good credit score, and I'm going to get a loan, and I'm going to buy a house. And he was so proud, and you could just see, that's health, right? That's a way to make sure that that young man stays healthy for a lifetime. So we're gonna have a conversation here with some people who are really sort of trying to make this business model work. We know that we spent $4.4 trillion in medical care last year. About 85% of that's for chronic disease. Most chronic disease is avoidable, and we know that we spend about $1 trillion treating the disease that is a byproduct of living in poverty. So we know that this is totally messed up. We need to spend that $1 trillion upstream to make sure that that disease doesn't develop in the first place. And these two are pioneering a business model that I think has a lot of promise to do just that. So I'm going to ask them to discuss. This is Chris Herman, Executive Vice President and Chief Investment Officer at Enterprise Community Partners, the largest community development financial institution in the country. That's a nonprofit bank, more or less, but they often partner also with mainstream banks that you've heard of, the JP Morgan Chases and Wells Fargos and Bank of Americas of the world. And then Bashar Shakir, who is, I love this, Chief Health Officer for Kaiser Permanente, and somebody who has a long history of treating patients who are really struggling in difficult circumstances as a physician, but now in a role where he is really leading one of the largest health providers and insurers to really see the light of making those investments upstream and investing in the social determinants of health in the areas where they do business. So I'm going to start with you, Bashara, and just tell us a little bit about how you came to this concept pretty easily because of the work you did. You were Chief Health Officer in the city of Chicago. Now you're in a big organization. How do you get others to think the way you think in a big organization like Kaiser Permanente?
Well, good morning. Thank you so much for joining here today, and thank you for having me here. Well, David, I mean, I think for me, it really boils down to the work that we do as an organization. We are the largest integrated health system in the country. We have 12.6 million members, and our mission is pretty simple. We're about improving the health of our members and improving the health of our communities. And truly, those go hand in hand, because if you think about it, there's no way we're going to be able to improve the health of the communities where Kaiser Permanente operates if we're not doing a really good job at improving the health and well-being of our own members, 12.6 million members. But make no mistake, there is no way you can optimize the health of those members if you're not thinking about the conditions for health and equity in the communities where those members live. And that's why it's a no-brainer for us. Yes, we're going to deliver the top-notch quality care that we deliver for our members, but if we're not thinking upstream, we're missing a lot of how to optimize the health of those members. So it becomes very clear investing in upstream drivers of health, whether it's housing, economic development, transportation, financial security, all of this becomes an integral part of how we think about the health and well-being of our members and our communities. And Rosa said something very, very relevant. She said there's no economic development without health. And there's really no health without economic development as well. Like, it's a no-brainer for us.
Yeah. We have a great, if you get a chance to check on our website, a great conversation between Surgeon General Vivek Murthy and our President John Williams saying exactly this, that health is wealth and wealth is health. I mean, This is so fundamental. Chris, so it's interesting. Maurice Jones, when he ran LISC, he said at one point, many, many years ago, he said, in the future, I'm going to get more money from hospitals than banks. That didn't happen, right? But you guys are really, I think it will, eventually, and you're kind of setting the model on how that might work. Can you tell us a little bit about how you've taken the investment from KP and deployed it into communities?
Yeah, absolutely. And again, thanks, David, for inviting us today, and glad to be with Bashara on this panel. And we have enjoyed a great partnership with Kaiser Permanente, which I'll talk about in a moment, but really just to set the stage a little bit, Enterprise has been at the affordable housing crisis for 40 years. We're celebrating our 40th anniversary this year. And what we've learned over that 40 years is that housing doesn't exist alone, right? Housing exists in a community with its access to healthcare and jobs and transportation. And so over the last decade, Enterprise has been really intentional about forming partnerships cross-sector with the healthcare sector, for example. It started with convening a working group of healthcare and housing practitioners just to sit around a common table and start speaking the same language and explaining what our challenges are and hearing what healthcare challenges are. And that really led to a multi-year discussion about how Enterprise and Kaiser Permanente could joint venture essentially in an investment strategy to address our shared goals. Enterprise coming at it from the background of a housing focus, and Kaiser Permanente, of course, from a healthcare, but with a shared understanding that there is real deep overlap between those two worlds, and we need to be working together if we're going to succeed. And so Enterprise and Kaiser Permanente formed a $100 million partnership back in 2018 or 19. So it's been ongoing for multiple years. The capital was split $50 million for an equity strategy, equity as in capital, meaning it's at-risk investment capital focused on preserving affordable and workforce housing. That particular piece of our work is really dedicated to Kaiser's headquarters footprint in Northern California. But in addition to preserving affordability, we agreed that we would focus on health. We would do several things. We would engage a public health professional to do health action plans on every property we invest in to help educate us and our partners who help us operate these properties about how we're either positively or negatively affecting resident health and what we can be doing to be more intentional about being additive and not detractive from resident health. And we also do resident surveys, both immediately upon acquisition of a property focused on health and then ongoing every year thereafter. On the debt side, it is a more traditional CDFI strategy where we're borrowing from Kaiser Permanente and relending into communities. That's a national footprint. And that is great because it's companion capital. That capital can cycle into projects and out of projects and has achieved a lot of scale, whereas the equity strategy of $50 million helped preserve about 1,100 units. The debt actually helped support about 5,500 units. So getting at one of the goals we had of scalability and being able to touch a lot of units was important in how we kind of came to that strategy.
I'm going to go to you next, Bashara, and talk a little bit about just get really specific, really concrete about where this money is landing, what's getting built, how it is improving health. But before we get there, I just wanted to comment. I think, Chris, you mentioned equity, and we've been doing this work with community development and health for a long, long time. And a lot of the health folks in the room, and I know I've talked to many of you at the breakfast, are coming from that side of it. And I remember early on people saying, what's equity and what's debt? And can you just say money? Because we don't really know what you're talking about. And we can get into this sort of our own sort of nomenclature and our own acronyms and whatnot. And but I was just at Yale a couple days ago, and someone from Robert Wood Johnson Foundation was there. She said, "Yeah, I couldn't understand why you kept on talking about the CDC in Atlanta." And I'm like, "No, I was talking about community development corporations." So there's lots of this language stuff that we're still struggling with. But Bashara, paint a picture for us. How's this money landing?
Yeah, so Chris mentioned the $100 million we have in partnership with Enterprise. But if you take a look at our overall investment portfolio, actually our board of directors have approved $400 million of our investment portfolio to be invested in projects that not only is going to give you a financial return on investment, but also social return on investment. And I want to spend a moment on this because I think this is relevant. When I came to Kaiser Permanente and I started meeting all these folks, and I I got a chance to spend a lot of time with our CFO and then our treasurer, and I got to learn a lot about our investment portfolio. And look, we're a not-for-profit organization, and just like a lot of companies, we have an investment portfolio that we invest in the market with the purpose of getting financial return. And we're not for profit. This return is not going to shareholders. This return is going to our communities, to our members, and to help us drive affordability. And that's when we started asking ourselves with the treasurer, with the CFO, and with our board, are there opportunities for us to leverage this investment portfolio, dedicate a portion of that investment portfolio where we are still going to invest, we're still going to expect some financial return, but the most important part that we'd want to achieve there is the social return on investment. And that's, I think, where the board got really excited about the opportunity of investing in affordable housing, which directly connected to health. You know, there's no doubt in so many people's mind now that housing and health are so interconnected. So we started with that first $200 million back in 2018. That's the first $100 million that we've partnered with Enterprise. But if you remember at that time, it was covered all over the news for the $200 million impact investment to advance affordable housing. And I'm so happy to see now this is becoming part of mainstream investments. You see Apples and Googles of the world and Microsoft of the world doing hundreds of millions and billions of dollars. So all of a sudden, our initial $200 million became a small part of what we're seeing now. And this is the type of excitement that we'd like to see. So we took that initially $200 million, and now that $200 million is on track to preserve or add about 15,000 affordable housing units in our communities. And with the $400 million, we expect that we're going to be at about 30,000 affordable housing units by 2030, preserved or added. That's the type of investments that I think will make a difference in our communities, not just for our members, but for the communities in general. You know, lots of details there. You know, we're investing in about 105 properties right now. We are doing pre-development capital loans, which I know is a little bit riskier, but it works well in our environment. We're partnering with LISC to try to figure out how we leverage our investment portfolio on the economic development, not just on the housing. So there are lots and lots of activities there. And at the end of the day, when you see these thousands and thousands and thousands of units preserved or added to affordability, that's truly what's going to make a difference in our communities.
So if I could add to that, because I think that that's really important to set the stage of scale, and scale matters and is relevant. And if I could just kind of take it down to a micro level and describe a property, because I think there's utility in that. You know, Kaiser Permanente's investment with Enterprise allowed us to support a local nonprofit in Oakland, the Unity Council, acquire a really dated 55-unit building that was in disrepair. It was subject to absent ownership. And through the Health Action Plan, our resident surveys, we engaged with residents. We learned a lot about what they wanted to see in their community. So in addition to making the community safer through seismic retrofitting and security measures, we also embarked on a partnership through Kaiser Permanente with Kaboom to really repurpose an entire courtyard and turn this property into, from a property into a true community. Painted murals on the walls, repurposed playground from Kaboom, sitting areas, and just really changed the dynamic in a significant way. We gave children a place to play. Previously, it was just a concrete footprint, right? And that's where I think, in addition to the affordability, the improvements to the physical building, the creation of new amenities, Kaiser Permanente also introduced us to their Nurse Scholars Program. So there's medical support in the community on a weekly basis, setting up a table and working with residents. So that's where it goes from the dollars to the people. And I think that's a really important part of this, where healthcare is so intentional, right? Oftentimes we have investors investing in affordable housing, and something Bashara said about this isn't just about investing. Yes, the financial return matters, but they've really put on a level playing field the social return, the renter outcomes, and ultimately what the residents experience.
That's really powerful to hear how that sort of lands in a place. I know that project, and I know Chris Iglesias, who runs the Unity Council, who is a good friend. And Years ago, we worked on a collection of essays called Investing in What Works in America's Communities, and we kind of came to this realization when we looked at places that were really turned around, like Harlem Children's Zone, Neighborhood Centers, Inc. in Houston, purpose-built communities in Atlanta, that they usually had like these 5 elements, that they were place-based, cross-sector, they had trust from the community, they were data-driven, and they had some kind of a backbone organization like a community quarterback. And I said, you needed those 5 elements. The other 2 things you usually needed was a charismatic super genius who had a close friend who was a billionaire. And Chris Iglesias is a charismatic genius.
Most genius.
And Bashar is a billionaire. So that works. Sure. So how do we? Sure. So one of my professors early on, Langley Keys, who was a professor to many of us here in the room, had this term routinizing the extraordinary. So how do we routinize the extraordinary? How do we get away from? I think there's leadership everywhere. There are a lot of billionaires, but not enough. So how do we get to the point where we can get more Chris Iglesiases making those differences in their communities? How do you scale this? What are the obstacles? And Bashar, maybe you could talk a little bit about, like during the pandemic, you mentioned that you had some funds that you were trying to get out the door that just couldn't get deployed. Maybe you could touch on that a little bit.
Yeah, so a couple of things. One, I think this type of work, and I see many of my colleagues from health systems here who also are doing amazing work. This type of work at the intersection between health and economic development is not for the faint of heart. This is the type of work that's going to require a lot of rolling up your sleeve. I see Thea here. I didn't get a chance to say hi yet, but I saw Megan there. You have to roll up your sleeve, and you have to be able to come to the community table with a lot of humility and a lot of understanding, with lots of open-minded behavior, and just sit there and listen and engage. It doesn't happen overnight. And that's, I think, what Chris was mentioning, is how do you keep that uber focus, uber local focus on community partners, capacity in the community, you coming with a lot of humility and some resources, and how do you think about scale? That creating that balance is a challenge, because I can tell you it's a lot easier to just say, here's a program how we can take the scale, and then you can just pop up shops across the country. It just doesn't work like that. So it's going to require that deep community engagement, deep co-design, and that takes a lot of time. And for a lot of people in the corporate world, and I love our Treasury Department people, and they want to make sure that things are moving fast. And sometimes things move fast, sometimes they don't. And I think one of the learnings of working, like for folks in CDFIs, they're used to this. It takes a long time to build all kind of different, capital stacking, all these terms that I had to learn over the last few years, find different sources of funding, and then you find a full package. That's not how necessarily people like to work in different sectors. So we have to learn with each other. We have to learn from each other. We have to help our treasury folks identify different investments, portfolios. Like our portfolio is not just debt, not just equity. We're doing this pre-development capital loans. It's a little bit riskier, but it moves faster, and it's a space that we got comfortable in. So, there's lots of, our partnership with SDS, for example, Capital Group in Southern California, where we've invested $50 million. Their focus is on, they're going to put all the funding without government funding, and that's going to turn the time much faster. Yeah. The building will be hopefully faster and cheaper. So that's the type of things that we have to create a portfolio for things. So in a nutshell, you come to the community, sense of humility, co-design with the community, lots and lots and lots of conversations. It's going to take time, and you have to figure out how to do that at scale.
Chris, I'd like you to take the other side of that, because that's so helpful to hear from that perspective. Like, how do you absorb that capital? Right? We used to call it. There was an old term, capital absorption. It was a terrible term, but it really described this problem. Like, you're getting hundreds of millions of dollars from all these corporations. They're wanting to deploy it, but like all this money in the pandemic relief effort, ESIP program, you've got the money in the climate space that needs to get deployed. We're not sure we have the pipes and the straws to get out into the places where those dollars are needed. So I want you to talk a little bit about that. Before I go to you though, Bashar, how much money has Kaiser invested in the upstream social determinants of health under this under sort of a broad rubric of that?
Yeah, I mean, if you look at our community health budget, we spend about $3 billion or so a year, and a good chunk of it goes to support our members with their healthcare needs, but a lot of it is also invested in upstream. The $400 million that we have in impact investment is one example. We do about $120 million in philanthropy every year. We do a lot of activities. We average about $3 billion or so a year in multiple ways. But that type of upstream investment is so critical in an organization like Kaiser Permanente. We're in this for the long run. And in many of our markets, we're 20%, 30%, 40%, 60% of the market. You know, when you have that much penetration, those investments in the communities, it's just absolute no-brainer.
Yeah, that makes sense. So Chris, you're kind of in between the community and these big institutions, and you're trying to deploy that capital. What are the obstacles? Where are the places you're finding some real traction?
Yeah, it's a tough spot to be. You know, I think it's so interesting because I do sit on both conversations, and I'll sit around a table, and actually we have a meeting today with your colleagues, you know, our monthly check-in, and the feedback will be like, can it go out quicker, right?
Well, of course.
Why isn't it faster? Why aren't we able to do better on returns? Why can't we sort of make this intervention happen, right? And those are fair questions. On the receiving end of the capital, the Chris Iglesias are saying, you know, who is the head of the Unity Council, you know, why can't the capital be cheaper? Why can't it, you know, why can't we just get grants, right? You know, the pandemic is not over, guys. Our communities are still struggling, right? Like Chris said that to me at a meeting last summer, you know, that, hey, people are moving on, but the residents in our buildings are still struggling, right? Like, so we sit in between these challenges, and I think that what we found is just a need to have an open line of communication. In the beginning of our investment strategy with Kaiser Permanente, we weren't doing monthly calls. Right now we're on a monthly cadence to be really transparent about what we're hearing and seeing in the market. And also to remind the investor that you sort of hired us for a reason, to be disciplined, right? You didn't hire us to make grants, you hired us to make investments. And you know, the pandemic, my colleague says, has been hellacious, right, for owning and operating and serving low and moderate income residents. So we, as the fund manager on behalf of Kaiser Permanente, have tried to be really disciplined. That means things move a little more slowly, right? But in the long run, like, our role is to deliver the reasonable financial returns KP has asked us to deliver, and the health outcomes and impact outcomes that we've designed for residents. But we learn every day. Bashara referenced the sort of flood of capital that followed your announcement, right? And I think that's very notable, and that's great, right? But that just means there is more supply, and there are sort of, you know, better products emerging, or like, you know, developers are attach or see a new shiny object, right, and focus there. So, you know, that all is part of our responsibility to balance and try and navigate through. And it's just something that I do think takes patience, takes really good communication and transparency, and a shared commitment to the ultimate goal. The capital is not doing anything for the community if it's not in the community, right? So there is a responsibility to make that capital make its way into the community and have the impact it has. So glad that we finally finished our deployment earlier this year of on the equity fund, the $50 million, and are seeing that now really manifest itself in the community.
You know, I do want to just to add a little bit to what Chris described about the conversations that happens in the community. And as an organization, our role in the space is also not just on the debt and the equity side, but it's also on the philanthropy. I'll give you one example. The Purple Line corridor in the Maryland suburb of DC, they're adding a light rail there. And as you know, when there's a light rail, there's going to be transformation in that community. There's about 17,000 affordable housing units there along that corridor, and we are committed to be able to preserve that and keep it in that community. So on the On the philanthropy side, we're supporting a lot of the community coalition building that's happening. We're supporting a lot of the work that's happening around capacity building, educating the local government. You know, Princess George's County now is using the right of first refusal opportunity. They've used it 6 times to preserve about 1,600 units. So we're doing that on the philanthropy side, but also we are one of the main contributor to a rotating loan fund that's available there to preserve these affordable housing units. And we've contributed, I think, 5 or 7 out of the $11 million that's part of that loan fund. And that rotating loan is already deployed into 6 projects that's going to preserve about 600 units or something like that. But I think that's what I've mentioned earlier. You have to be in the community, understand the community, and you have to show up not just with your loans and financial investments. You also have to show up with the philanthropy side, and both those come together.
And I would just add, because I think that's a very good point. And for enterprise, we've talked a lot about capital and aggregating and investing, but there's also a programmatic element to this for us, right? And to give an example of something we've recently launched here in New York, which is a partnership with Medicaid insurers to help encourage Medicaid insurers to be the payer for pest control in the apartment homes of children who experience asthma spikes on a routine basis. And so this is where it's not that we raised $100 million, but Enterprise was a partner in facilitating a little over $1 million of first loss capital that enabled Medicaid insurers to be that preventative payer for pest control, so that it reduces the cost for the insurers of children showing up in their emergency rooms for treatment. So it's not all about capital, it's about grant making, it's about programmatic partnerships and coming up with new innovations to bring the healthcare sector forward.
That's super interesting. We've got about 5 minutes left, and I want each of you to have sort of a chance to make a closing remark for a couple minutes each. But this idea of this sort of different types of capital doing different parts of the project is so essential, and it's and getting to the point where it's sustainable and it's you can get a market rate return for it is also important too, because even though we sometimes feel uncomfortable about talking about, I often get accused of like, you're making money off of poor people. I'm like, look, there's $60 trillion in the capital markets. There's no way we can grant our way out of this problem. We have to get to the point where there's a financial return, because that's where the money is. So you're going to hear the next panel is going to go a little deeper, I think, into sort of an example in the Boston area you'll see how some of these pieces link together and how you sequence it and how difficult it is, but what the payoff is when you get there. So I'm really looking forward to that conversation. And before we end, I just want to give each of you 2 minutes to sort of hit on some things that we may not have had, I didn't ask you about, or things that you think that the audience should know about. Bashar, why don't you go first?
Oh, I was thinking Chris.
Oh, Chris.
Since I'm the billionaire, I'll get to go last.
Save the best for last.
Okay, Daddy Warbucks, you could just...
I would say just the future, right? That was something you had asked me about earlier. Where are we trending? I think it's really focused on upward mobility, right? It's recognizing that keeping rents affordable is a piece, right? But the upward mobility of our residents is so key. Health is wealth. I heard that referred to earlier. Kaiser Permanente has been a really strong partner with CBA in encouraging on-time rent reported to the credit bureaus, for example, to help enable the increase in credit scores for low and moderate income renters who otherwise aren't building credit. There are all kinds of models emerging focused on wealth. Enterprise is working on a fund that will implement a cashback rewards program for renters and a form of shared equity for them to participate in the financial success of their communities. So that's what excites me, is sort of continuing to push the envelope on impact.
I love it.
Yeah, I think for me, we've surveyed 10,000 of our members just recently about their social needs. And, think about that for a moment. Our members get their coverage through their employers. The overwhelming majority of our members are actually employed. And 3 out of 5 of our members said they have at least one unmet social need in the last year. That's either financial problems, housing instability, food insecurity. 3 out of 5. And even 1 out of 5 have 3 or more of those. So there is no doubt that in today's environment, we have to be thinking about people's social health, the same way we think about their mental health, the same way we think about their physical health. And as an organization, we're committed to making sure that we're screening our members for social needs, connecting them to resources. At the same time, we have to be working more upstream. And our work in housing, and now we have a full portfolio around economic security, I think is integral to that part of our commitment to our members and to our communities. And you're going to hear lots of other amazing examples. And I think the healthcare industry is ready, is doing a lot of the great work. We'd want to support that. There are organizations like the Healthcare Anchor Network that's bringing 70 plus healthcare systems from across the country, looking about what role they can play. So I'd encourage you to check them out. We're one of the founders of this network. And there's a lot of work ahead. And conversations like these are really, really important. I went to medical school. I didn't even know what CDFI is. I still, when I hear CDC, I immediately think about the CDC in Atlanta. So it's hard, but it takes a lot of work, and it's really, really important work. And thank you for hosting that. And David, thank you for your outstanding leadership and a very, very long time to bringing this concept. I think we were having dinner the other night, and I remember one of our very, very first conversation back in, I think, 2012 or 2013, hearing you talking about that and why this is important had really had a great impact on me, and it's great to be sitting with you here on the stage today.
Oh, Bashar, thank you. Thanks very much. Oh, I appreciate that. It's interesting. I mean, it takes a long time to learn each other's language and to sort of understand each other. And I think about, we do a survey here at the Federal Reserve on economic decision making, and between 35 and 40% of the population says they couldn't pay for an unexpected $400 expense. So this is to your point about those 3 out of 5 of your members. And when you think about I love that you know how to talk about community development corporations and CDFIs, and I get to talk about allostatic load and and telomere lengths in terms of DNA strands and whatnot. But when you are in a situation where you can't, you don't cry over spilled milk, you're going to cry over it if you can't afford to replace that milk, and your children are crying, and that creates a stress. And the epigenetics of that are really so devastating that it's very expensive. That's why I often say the status quo is stupid and expensive. We can go upstream, we can fix these problems. We have the ideas, we have the money. What we don't have are the business models, and that's what you're going to hear next is an example where we're going to go deep into a business model on that, and you've got an example here on stage of some real leaders. What we need is 100 more Bashars and 100 more Chris's to sort of really make this a reality for everyone. So thank you to the two of you for sharing your insights, and I'll ask the next panel to come up.
Thank you.
Thanks very much.
Breathe, my friend, breathe. Yeah, it's good to see you. Good to see you.
Thank you.
Come on.
Well, good morning, everyone. It's great to be here, and Ebony, glad you made it. I know it was a little bit of a scramble at the airport, so it still feels kind of amazing to be in person, right, all together, and we can sometimes forget what it takes to do that, so thank you. So my name is Maggie Superchurch. I'm a visiting scholar here at the New York Fed, which is a lot of fun. I get to work with an amazing team that's really thinking about big questions and issues around health and climate and impact investment and how we get more people into the game. Prior to joining the Fed as a visiting scholar, I was vice president for Healthy and Resilient Communities at Conservation Law Foundation up in Boston, one of the co-sponsors of the Healthy Neighborhoods Equity Fund, which we're going to be talking about today. So it is a real treat to be at the New York Fed and with my colleagues and friends from the Healthy Neighborhoods Equity Fund to really talk to you today about the journey that we've been on. And I appreciated Bashar's comment that this work is not for the faint of heart. It's hard, but it's incredibly rewarding. It's incredibly important. And now that we're about a decade out from some of those early conversations in 2012, 2013, we wanted to share some of what we've learned and some of what is on the horizon, we hope. So just to say a little bit about what the fund is and kind of paint the picture for you before we jump in and I introduce each of the panelists. For those who aren't familiar with it, the fund is a private equity fund providing very patient, low-cost, long-term capital investment in development that, for a whole range of reasons, we hope and expect will promote health. And so it's the direct investments are in mixed income housing, commercial space, that can be home ownership, that can be rental, and really thinking about housing in context of neighborhood and all the various ways in which development can improve or potentially harm health. And so as part of setting up the fund, the partners involved really thought hard about how to measure impact. We know there's so many things that impact health, but how do you begin to wrap your head around all those different pieces and then build a system that really reflects that understanding? And so the team developed something called Health Score, which is basically an impact underwriting structure that goes alongside the investment underwriting. And that was an important kind of early move in thinking about how to set the fund up. So the fund is well on its way now. We'll be investing just north of $70 million in 3 states, Massachusetts, Rhode Island, Connecticut. And that work has really happened thanks to close working partnership from healthcare, who have not only brought dollars to the table, but have helped us collectively on the community development side really understand how to think about these issues and how to learn each other's language and how to be much more systematic in the ways that we integrate health, across the board in real estate development and community development. So just to set the stage, I just want to take you back to a day last May when several of us, unfortunately Ebony wasn't with us, but the rest of us were standing together in a neighborhood in Boston called Dorchester. For any of you who know Boston, you'll know Dorchester probably. On the site of a development that for many years had been a gas station, and then the gas station closed, and then it was a vacant lot. It's across the street from an elementary school. And on that day, we were celebrating the completion of a development that the fund had helped to finance, but also celebrating the broader sort of 10 years of work on this fund. And today, that site is home to 14 rental apartments. They're deed restricted for 30 to 40 years. They're passive house certified, which means they're incredibly energy efficient. So those units are using probably 70% less energy than a comparable new built development, which particularly as we look at energy prices these days makes a big difference on the bottom line and a big difference for climate. The development has a ground floor business called Fresh Food Generation that is owned and operated by a woman named Cassandra Campbell, who's just dynamite, who grew up in the neighborhood, learned to swim at the school across the street, and was absolutely delighted to move her food truck business into a bricks and mortar facility on the ground floor. So they had prepared empanadas and all kinds of amazing things that make me hungry when I think about them for this event. And the developer of the building, Travis Lee, also lives in the neighborhood, has lived in the neighborhood 20 years or so. Very mission-driven developer, doesn't have a ton of his own capital to work with. He's not a sort of a big institutional developer, but really cares about this neighborhood and really wanted to do the right thing. And so collectively, we're there to really sort of mark this moment and say, as you walk by, you think, well, this fits right in, right? Here's this beautiful building, got a great business on the ground floor, it's close to the train, it's close to parks. But a lot of what you can't see is what it took to make it happen. So all the community meetings the developer had, all the energy efficiency features, all the ways in which the affordability translate into greater upward mobility, greater economic security for tenants. So both those visible and invisible features are part of what make this work important, and also, frankly, what make it hard. So we want to share with you from this team's perspective, part of the journey, some of the struggles. It's never perfect. There's always more to learn and always more to do. But delighted to be at this point and sort of moving towards what we hope will be broader adoption of these kinds of ideas. So to kick us off, I'm going to ask our panelists to introduce themselves and share a bit about their role and how they got involved in the fund. And we're going to kick it over to the other end and start off with Ebony. So
awesome. Hi, everybody. I am Ebony Perkins, Director of Impact Investments at United Healthcare. We got involved with the fund because we have a core philosophy that it's our role and responsibility to really try to contribute to the overall positive good within society. And as a large insurance company that serves, at least on our Medicaid side, our community and state side, 8 million lives, we know that it's our responsibility. We recognize that social determinants of health, I know in the previous panel they discussed the stress effects of it all, and how stress can lead you into the health system. And so we decided that it's important for us to address the whole person, if you will, and all of the effects that are happening and affect their daily lives. And we knew that this particular fund would help us achieve that goal. So yeah, that's why and how we got involved.
Great, thank you, Ebony.
Hey everyone, I'm Dr. Megan Sandel. I am our place-based investing lead at Boston Medical Center, and what that means, and I want to acknowledge team members that are with me today, Dr. Thea James, our Vice President of Mission, because this is teamwork is the dream work and how we get this done, and it's not for the faint of heart, as Bashara talked about, is this idea of Boston Medical Center is a proud member of the Healthcare Anchor Network, and for that, it is not just thinking about place-based investing, but place-based procurement, place-based hiring as ways to make the communities that our patients live in healthier. And so in a lot of ways, we came to the Healthy Neighborhood Equity Fund as our first signature investment in doing that place-based work. It was serving the communities where predominantly our patients were living. We were really excited about something that not just financially scored, but also did a health impact score. And for us, it helped us to start on a journey of place-based investing and doing signature investments. So really excited to talk about it more today.
Great, thank you. And Kathy?
Hi, everybody. Great to be here today. Thank you, David. So I'm Kathy McGilvray. I'm the Director of Investment at Massachusetts Housing Investment Corporation. We are a CDFI based in Boston, but we work throughout all of New England and do more than just housing, so we have a name problem, but we'll work on that. I've been there almost 20 years. I manage our originations, underwriting, and closing team across a variety of products. And one of the things I dabble in is when gaps are identified in the community development finance marketplace, I work on new product development, which is exactly what this is. Maggie and I have been in this work together for, I think, almost 11 years now, which started with a regional planning organization that was identifying the gaps in financing for transit-oriented development in the greater Boston area, and identified patient capital for mixed income, mixed use projects in emerging communities as one of those gaps, which is exactly what this fund is meant to fill. And I just want to say that one of the key aspects of this is really Conservation Law Foundation's best-in-class kind of impact tracking in the health score that Maggie mentioned. That was really the thing I think that brought BMC along in the beginning, and that was hard fought. Megan and Thea did a lot of work to make that
we will talk about that.
Yeah, we will talk about that. And really is the thing I think that motivated this anchor investment in the second fund by United Healthcare at $25 million. So really happy to be here today and to get into the details.
Great, thank you so much. So let's start with motivations. Yeah. So I think everyone's in this room because we know and understand and believe that health and housing go together, that you can't have healthy communities without secure, stable, affordable housing. And as folks said earlier, economic development is central to health. But there's a lot of space between recognizing something is true and doing something about it, right? Yeah. So you're looking at the people who are doing something about it, and that takes some effort. So I would love to hear from each of you, from your perspective, organizationally, institutionally, sort of what really motivated you to get involved. Take us through some of those early conversations and maybe a little bit of a perspective on kind of what did it take to get it, to the point where you could actually close an investment. And would love to hear from our healthcare investors to start with. Yeah.
I may jump in just because in some ways it was a hard fought, let's just be real about it. So for us, it was, let's go back to 2017. Dr. Thea James, our Vice President of Mission, and I went to go meet with our CFO at Boston Medical Center, and he's an amazing guy. He actually quoted Maslow's hierarchy to us. What CFO does that, right? Absolutely, totally on board when recognizing it. And we brought him the Healthy Neighborhood Equity Fund prospectus, and we're saying, we're interested in this fund. We want to talk more about it. And he said no. He was like, not interested. And in some ways he brought in our treasurer, and our treasurer was like, oh, we brought this to our investment advisor, and they were like, it's a dog, we're not doing it. It was so no. Now, again, Thea and I are tenacious. And so we said, could we do a second meeting? So we did a second meeting, and they said no. We did a third meeting, they said no. So then we changed tack, and we invited our treasurer out to the site of one of the investments that the Healthy Neighborhood Equity Fund was doing. And it really was. It was a hole in the ground. This was a former bus depot that was, closed down because of amazing community action around why were the bus depots in communities of color with higher asthma rates. And they got it shut down, and that land was made available to a community development corporation, and they were starting the first of these investments where they had an amazing health impact score, because they were not only building a new building, they were actually trying to finance a grocery store on the first floor, all these great things. And so we got her to go to this, and then we went to a local cafe, and that's how we got to Maybe. And then we got to Maybe, and then we did the deep, made you guys come multiple times, got our, just went through it, and literally were like, this is good enough for Kresge Foundation, it's good enough for us, sign it, this is good. And I think that it just, if I can give you one piece of advice, is don't take no for the first answer. You have to get just people, and get your finance people out of their offices and get them into the community so they can start to just see differently. Finance people, they've chosen to work at a healthcare institution, not a bank, right? So they have a mission orientation that you got to tap into. And one way to do that is to get them out into the communities they're serving, get them to start to think differently and do it. And that's how we did. We did a relatively small investment, guys. $500,000 was our first investment. But for us, it was the first Boston teaching hospital doing that got another Boston teaching hospital to invest $1 million in the second fund. It got, other, an amazing healthcare investment from United. And I think those are the types of things where, just really stay after it, because I do think it's not for the faint of heart, to quote Bashar. I'm gonna steal that over and over again. But it really is, it's so rewarding when you can get it across the finish line.
Yeah, I think piggybacking off of what you said, I know we really value relationships and partnerships above anything else. Is this a good relationship? Is this something where we can work together to make sure that we have the intended impact? And you're right. It mattered to us that you all were involved and that you helped with all of this. It helped bring us to the table. I think for us, on our side, thankfully, we have a lot of buy-in and support from our leadership. Even our CEO has made a public statement and commitment to addressing health equity across the organization. And so this particular fund, it aligned closely with our org goals, the direction that we were moving in. And to be honest with you, we knew that they were the experts. Yeah. We knew that they knew exactly what they were doing, and the health criteria that you used, it changed the game. They were able to define what a healthy neighborhood looks like and measure it, so that we can really see the impact that we're having and make sure that we are having the intended impact that we hoped. But for us, as you can imagine, a large company, we have as I call it, a robust
review system.
Yeah, a robust review system, a robust underwriting team, if you will.
I can attest to that.
Yeah. So for a $25 million investment, we did have to make sure that we dot all our I's and cross all our T's, and it took some time, but I think it was worth it. Mm-hmm. It's something that we're really proud of and excited to be a part of.
Fantastic, thank you. Well, I want to shift to Kathy and get the perspective from the intermediary, the co-sponsor, the fund manager, the person who's sitting in the chair between, I think as the last panel alluded to, where the money is and where the work is on the ground, and sort of trying to triangulate that. And I think with the additional layer of 2 sponsors in a fund, which is also unusual, and trying to bring all these sort of different skill sets together to build something that frankly hadn't really been done before. So Kathy, can you talk to us about why MHIC got involved and sort of what it's been like to sit in your seat as someone who's really managing and air traffic controlling all these different pieces?
Yeah, so MHIC and as well as Conservation Law Foundation, as you know, we're involved with the Metropolitan Area Planning Council's planning around what we should do around transit. That was kind of the seed that built this fund. And fundamentally, MHIC's mission is to find gaps in the community development capital marketplace and fill those gaps. So it's actually it sits right at the nexus of our mission and our motivation, because one of the things that was really appealing about this fund is the potential to unlock health system dollars to bring to community development, because we've been tapping bank dollars all these years, mainly Community Reinvestment Act motivated, but to bring in a whole new set of investors into the community development marketplace was really appealing. We knew to do that, we needed the robust impact metrics, and I just want to recognize Jenna Foote from Conservation Law Foundation, who's in the audience. And MHIC does not have that skill set. We are an amazing fund manager, we are an amazing capital raiser, we know how to underwrite real estate up and down and sideways, but impact metrics are not our thing. We actually struggle with that whenever we're trying to explain to people what we do, because we're 2 steps away. So we really needed Conservation Law Foundation's kind of deep ability to do that, and the team that, frankly, you and Bill Coleman built early on really made that possible.
Great, thanks, Kathy. So let's reflect a little bit, because I want to go back to this point about, there's a learning journey here, right? Where we started is not where we are is probably not where we're going, although there's some continuity there. And Healthy Neighborhoods Equity Fund is actually 2 funds. There was Fund 1, which was really the pilot proof of concept fund. That was $23 million and change, fully deployed. And then Fund 2, which has raised some capital, has deployed some capital, and is moving along nicely. And so together, those 2 funds are about $70 million. But as Megan indicated, this started with a $500,000 commitment from a Boston institution. I would note a safety net hospital that really sees and understands what it looks like when people are struggling with poor health, lack of safe, secure housing, inability to secure or get to work, feed your kids, all those things. So this is literally kind of the day-to-day experience that Megan and Thea and others have had at BMC. So not an accident that a safety net stepped up first, but it took time to build, and it took time to create a model that could be road tested. And we had not, and others had not really used this kind of impact scoring system before. And the other piece that's important in the story was really trying to think about how the research and evaluation side fits into the work. And so one of the things that happened in the early part of developing the fund was the launch of a separate but related research study called the Healthy Neighborhoods Study, funded by Robert Wood Johnson Foundation, that was really trying to work with residents in communities where development was happening, to understand the impact on health from the perspective of people who lived in those places. What was it that was making it easier or harder to be healthy? And how did people even think about that? Because we have a lot of data on things like demographics. Increasingly, we have better data on health outcomes, life expectancy, et cetera. There's not really a great database to go to say, what does it look like or feel like for you as a resident of this neighborhood to live through this process of change? So that's the kind of qualitative experiential data that the research team was trying to really get its arms around, working with resident researchers and leaders from MIT. So that was all launching in parallel in 2012, 2013. Fund 1 was proof of concept. We're now well into Fund 2. So what I want to talk to the panel about and get some feedback on is sort of what was learned in that process and really what's changed as a result of all that learning. Maybe we'll start with you, Kathy, since you've really been at this from the beginning. And how do you really see that evolution and the kind of the research and other aspects of the work shaping what is happening now?
Yeah, so I think I probably have the driest answer to this, so it's good that you start with me, because they'll be more exciting. So I think the main thing that we learned in the first fund, so the first fund had a ton of top loss in it, so a $21.5 million fund approximately, and there was $7 million of top loss in it. And we were trying to get about a 10% return from projects, which let us give our Class A investors an 8% return. All that to say that was a complicated capital stack, Bashara, capital stack to put together. It's frankly a complicated capital stack to manage as a fund manager. We were very successful in Fund 1. So one of the things that we could do once we had the proof of concept is have a much simpler capital stack. We have one class of investors now. There's just investor limited partners and MHIC as the general partner of the fund. We went from 30% approximately top loss to 5% top loss. And we're requiring lower return from projects, so 8% from projects to get 6% to the investors. So that, from a fund manager perspective, that's like a big change. Much simpler fund to manage, much fewer kind of players to play with in the ongoing cash flow distributions, et cetera. Another thing that we did was gave ourselves the flexibility to deploy up to 20% of the fund to areas of opportunity. We had to pass up a couple of really incredible transactions that would have brought family-sized, affordable housing to communities with, for example, great schools, because we had a very strict baseline. The communities we're investing in have to have health disparities. So we decided, part of getting at better community health is to put affordable housing in communities of opportunity. So up to 20% can go to communities of opportunity. And I think the other big shift was we expanded the geography of the fund, both to think about other health system investment we might be able to attract, but also to serve Southern New England, Rhode Island, and Connecticut. So I think those are the big shifts that we made.
Yeah, I think for us, I want to echo again something that Bashar said around, and it's no surprise Kaiser has been an amazing leader, and we're just always wanting to copy amazing things that they've done, is we started thinking about this as a housing investment. And in a lot of ways, we've really opened the aperture now to be like, you know what? We really do want to think about economic development. And it is to us about upward mobility and wealth building. And what are those opportunities looking like? And so in some ways, by having such a good experience with our first investment, it opened our eyes when, MHIC and Conservation Law Foundation said, hey, that grocery store that's on the first floor of the building, their financing fell through. Would you show up for that? And we were like, hell yes. Like, we want a grocery store in a food swamp. Like, yeah. And so those are the ways in which you start to think differently about investment and around how does a community, a healthy community, get built? And it's more than just housing. It's about good jobs. It's about healthier retail. It's about all of those things. And so it's really made us think differently and to start to think about that impact investing. I mean, I think that, people don't realize, we have so much data in healthcare, and yet we don't always analyze it with a place-based lens, like mapping where your patients live and starting to think differently. And I do think that, again, they're the same redlining maps from the 1930s, and we're not moving them in the status quo is stupid and expensive. Like, how do we start to think differently? And I do think it is different money with different focus and different intentionality is really how we're starting to think differently about it. And so, yeah, I think for us, it's the new financial tools, right, are really about what are the cutting edge ways in which we can use money to get different outcomes.
Absolutely. So United wasn't involved in Fund 1, but I want to give Ebony an opportunity to comment on anything that you want to share in United's journey. Obviously, this is only one of many investments that you've made in the housing space. So kind of what are you learning? What have you seen? How are things evolving from where you started to where you are now?
Yeah, I think it's very similar to what you said. This has helped us figure things out and see what direction we want to move in from our side. We have what we call a three-prong approach to our community investments, which include community grants, tax credit investments via LIHTC, as well as these social impact investments. And the healthy neighborhood score and the healthy criteria score has changed the game for us. And we have really started to look at, okay, what do we want the end story to be? Even just the way that the criteria, how they define a healthy neighborhood, and including walkability and safety, and even the environmental components, it's really making us think differently about, this isn't just a housing investment. As I mentioned before, this is a whole person investment. And finding unique ways to really make the most out of our investments, not just financially, but really what all can we incorporate? And so, yeah, we are starting to apply that same set of criteria to other investments that we're making across the country. So yeah, MHIC is not just having an effect on Massachusetts because they helped us learn. We're trying to spread the knowledge with other people too.
Can I add one thing
You
to
can.
that? Because
Please do.
another thing that we have heard from our Healthy Neighborhood Equity Fund developers is that they are taking the health score and overlaying that analysis, not at the same depth that CLF does it, but overlaying that analysis on every development they're doing. So they're like, yeah, we kind of thought we thought about healthy housing, but not in this way, and not with all of these different components.
Yeah.
So again, we're the health score is impacting projects even beyond Healthy Neighborhood Equity Fund. So it's pretty cool.
Great, thank you. So I want to shift a little bit to talking about public policy and regulation, because all of us live in a world governed by a lot of rules, and healthcare plays by a set of rules, and community development likewise. And those rules are changing. In fact, CRA may be changing a lot, right? And so we're thinking about what does that mean for investors like banks, but also like healthcare. And then at the community level, how do we think about zoning, development rules, and all the sort of the things that create the space we have to work inside of. And so I'd love to hear from each of you from your perspective, given the various kind of regulatory and public policy contexts that you live in. How does public policy either make it easier or harder to do this kind of work? And are there things that you could imagine would make it easier to do more and more quickly going forward? I know that's a big question, but would love just anything you want to throw in the mix here, because I think we are trying to make this work easier for everyone involved. I will open up. Whoever would like to start.
It's interesting. I think that most hospital systems are not-for-profit. And so we have a certain amount of regulatory reporting in the IRS and other things. And to an extent, our initial investment portfolio for Boston Medical Center was generated around a concept. In Massachusetts, it's called determination of need. Most states, it's called certificate of need, this idea that we as healthcare systems are building new facilities and other things. And are there ways in which you would then devote a certain percentage of the cost of those projects into community health initiatives, right? You're building things for person-based care. Why aren't you also building things for community-based and investing? I think there are real opportunities to get that codified in much more intentional ways. I would say Massachusetts tends to be much more, I would say, aggressive around counting those costs and making that a part of the approval process. And we were able, as the first Boston teaching hospital, to get an investment in a Healthy Neighborhood Equity Fund to be counted as something when we committed to the fact that when it got repaid, it was going to go back into a revolving fund. So this idea of where do you find the dollars? In this case, this was a dollar that we really wanted to think about. I think the only other policy change I'll just say is I think there are ways in which, whether it's risk-based capital from an insurer or it's investment portfolios from hospitals, where we really should be setting aside a certain percentage for more program-related investments, right? That aren't really focused on return, they're really focused on impact. And how do we kind of, again, there's a little bit of carrot, a little bit of stick, but I think sometimes stick is a better policy in terms of making things happen. And I just think there are real natural ways in which CRA-obligated banks and community benefit obligated health systems could be really doing powerful co-investing with the right policy incentives.
Great, thank you.
Yes, so I'll sort of build on that because Megan just said CRA, Community Reinvestment Act. For those
the pediatrician on the panel said CRA, yeah.
So exciting.
You heard it.
So I think about this both from the fund capital raising level and the project level in terms of policy. And so at the fund level, one of our early bank investors got a letter from the OCC that said this was CRA eligible, and that sort of opened the floodgates on the banks. 97% of the Class A capital in Fund 1 came from banks, in part because they were also familiar with MHIC from our low-income housing tax credit and new market tax credit business. So certainly, and then the DON was the motivating factor factor or one of the motivating factors behind BMC's investment in Fund One. At the project level, every single project has some form of public subsidy. So that is everything from, like, probably the least amount is like a TIF, a tax increment financing for one of our projects. But then some of them have a deep layers of the alphabet soup of affordable housing soft funds that are the state of Massachusetts provides. So I would say, what do we need more of? We need more of that. Yeah. We need more. And finding capital that doesn't need a 6% return, maybe needs a 2% return, would do a lot towards really allowing us to do the most impactful projects, drive more affordability. This is a mixed income fund. About 30% of the first fund was deed restricted affordable. Right now, 50% of the second fund is looking like it's going to be deed restricted affordable or moderate up to 100% AMI. So just, more cheaper capital is what we need.
Right.
Yeah, regarding policy, I want to make sure I stay in my lane.
Yeah. This is being recorded.
Right. But we actually have outside of our robust underwriting team, we actually have an entire policy arm of our line of business that's focused on that. We're beginning to explore ways we can work together on our community investments, but it's definitely something that we are looking into right now. Mm-hmm. But I'm open to having conversations to take that back to the group.
Thank you. So let's take one more question, then we want to open it up, I think, for some questions from the audience as well. But would love to hear from you all about sort of where do you see things going 5 years out? What do you hope we'll be talking about, if we're sitting here or something like this, and sort of what's on the horizon?
Yeah.
I think there are going to be more people coming into the party,
yes, 100%.
if you will. More investors who can see the power of these types of investments and want to take part in it. Mm-hmm. I don't know what that'll look like in terms of numbers, but I do think it's going to be a bigger and more fun party.
I think that's right. I am so excited about concepts of how to do investing where there is a wealth building component. I will, I'm a pediatrician by training. I joke a little bit that I talk more like a banker than I do like a doctor, right? I just use the word CRA somewhat fluently. And I think I was lucky enough to join Enterprise's board actually in 2016. And I joke at my first board meeting, I literally felt like I was in medical school writing down the abbreviations again to look up later, right? Like I actually spelled out LIHTC, very uncool. It's called LIHTC, but it was one of those things where for me it was like how do you start to understand why patients are sicker? And they're sicker because of economic inequities that are based on structural racism. And so for me, it was like, yes, I need to learn this language. I need to understand this. And so I do think these concepts of how do we not just help people with a stable home so they're not having to choose between rent and food and medicine, but how do we help them build wealth? Like wealth. If we learn nothing from the pandemic, wealth is actually what makes you healthier. So it is health is wealth, but wealth is health. And so for us, it is what are the roots towards wealth building that we should be going towards? And so and again, like I never thought I would get really excited to talk about like affordable commercial ownership. But I do think it is really about like how do we start to talk about not just housing roots to wealth and not just home ownership and rental, but like the in-between. And again, a shout out to Chris Herman around creating the Renters Wealth Creation Fund. Like, what are ways in which you can like create the financial tools to be able to do that? And then for us, it's really like, can you bake in condoizing the commercial space so that people don't get priced out of the rapidly gentrifying neighborhoods that make those communities who they are and what they are and the assets moving forward?
I don't like going after Dr. Sandel, but I will. Just because it's riffing a little bit off of one of the things that Megan just said, is one of the things we haven't talked about is we overlay expectations on all Healthy Neighborhood Equity Fund projects to hire minority business enterprises for construction and the development team, as well as to hire people of color in the construction. So basically in Fund 1, for every dollar of HNEF that was invested in projects, 91 cents went to MBEs. For Fund 2, we're at 96 cents on the dollar, and 72% of the people who've worked on the, 72% of the hours that have been worked in the construction have been worked by people of color. Awesome. If we can get that at a national level, that is building like individual construction worker wealth, that is building MBE wealth, like let's replicate, even if we just replicate that piece of it at the national level, that is transformational. So. Yeah,
absolutely.
See, that's the key takeaway. Transformational.
That's exactly right. You heard it here. Yeah. Fantastic. So let's open it up for questions. I think we have. Oh, there you go. All right. Right at it. I love it.
Good morning. Good morning. Titus Pierce, the Chairman, President, and CEO of Royal Bank of America. You guys said that health is wealth. In our nation, 91% of the country, that's 314 million people, have only a high school education or lower.
Yeah.
So if you want to get to wealth, right? Wealth is associated with academicians, right? Meaning you have to learn something in the brain. Our American people refuse to educate. So if there's a refusal to educate by 91% of the country, we're going to have a huge industrial wall at some point where only 9 people are climbing over the wall of wealth because 91% of them are staring at it saying they don't want to jump over it. So if we want to talk about the health as wealth, we first got to talk about how do we educate the brain to get the jobs that develop wealth. That's my point. Thank you.
Yeah. I will just note on this. So I do feel like getting to higher paying jobs is a really important part of it. I do think that we want to recognize where a lot of affordable housing gets built is in communities where the education system may not be the same. And so are there ways in which we can view, honestly, it's about the wall that you tear down more than the wall that you get over it. And I think that to an extent, we really do want to try and create multiple economic pathways and being able to not just do that with, say, a business or with housing, but also with getting people to higher paying jobs that allow them to be able to build assets over time.
Good morning. Thank you very much for this illuminating panel. I work at a housing justice tech nonprofit called Just Fix. I know there's a lot of contradictions in that phrase.
Yeah, spell it out again. Housing Justice Organization.
Justice Tech Nonprofit.
And it's called Just Fix. Thank you. Yeah.
And we focus on housing conditions in New York. And my question for all of you is, how do you make sure that housing is properly maintained? It's one thing to make access to housing possible, to build housing. But as we've seen in New York, we have a robust public housing system, hundreds of thousands of apartments. But if they're not properly maintained, then people suffer the same health outcomes, asthma from mold, broken elevators, and so on. So how do we do that? How do you kind of, in your space, try to make sure that those things happen? Thank you.
I know, I know that with us, we have what we call a health and housing fund where we are supporting affordable and supportive housing across the country. A large chunk of that fund is used on rehabilitating units all over. And I remember I visited one earlier this year that was in the middle of a rehab, and I got a tour of the before and the after, and so going on site like changes the game. Totally. But what I learned, it was a senior facility in North Carolina, and even just the way that they rehabbed the unit, they did a lot of different things. They got HVAC systems and reconfigured the kitchen. But the thing that I took away the most was the fact that the way that they adjusted that apartment complex or that unit, it made the time that it takes for an EMS unit or an EMS paramedic to get into their apartment to support and address the health needs of the senior citizen in that facility, it reduced the amount of time dramatically just from that rehab. And so we are I know we're being intentional about not only building from the ground up, but also making some of the changes in what's already existing.
Yeah, I'll just jump in. I want to give a shout out to another great health system, Nationwide Children's Hospital in Columbus, Ohio, that has put serious dollars into a home repair fund where they've been able to fund actually a home repair service. I am so jonesing to replicate that in Boston. And part of it is this idea of if you could be able to fund a creation where you can do lower cost renovation and rehab, you also could potentially help people with a high school education get a job that is a good job, and you may be able to help them spawn their own small business, right? So it's the triple win. It does require the intentional financing, like you have to show up with the right dollars, maybe marry some grant dollars with some investment dollars together, and I think that's something that we as health systems can do. But I totally agree. I think we have to start thinking differently about just the capital to build and the operating costs. We have to think about the maintenance costs to these properties. Otherwise, we're not going to create the healthy housing that we need.
Mine's a geeky asset manager,
I love
fund
it. Yeah,
manager
there we
role,
go.
but basically up front we make sure it's quality materials, quality systems, adequate operating expenses in the pro forma, and adequate replacement reserves, because that's where you often fall down, is you don't have the reserves to, like if the boilers go sooner than you expect they're going to or something, you don't have the reserves to fill it, and that's when things start to deteriorate. So just kind of upfront making sure it appears that the project can really thrive for the long term.
Yep.
Hey, Megan, can we do it like just rapid fire? We have three last questions here,
good.
and I know we're
Great.
almost out of time.
Thank you.
So if
Sorry about that.
we're going to give that. So if
Yeah.
you three can go really fast.
Okay, and I got a quick one. My name is Bill. I'm with Fifth Avenue Committee. We're an affordable nonprofit housing developer. I was wondering if one of you could just pick one project and give for the audience a quick snapshot of what the investment or loan was. Was it just construction? Was it permanent? Was it something ongoing to somehow, on a going forward basis, improve health outcomes? Just one example I think might be helpful for folks to hear.
Okay. All right, so we'll hold that.
Oh, we're going to hear
We're
the
going to
questions
hear
first?
three
Okay, got it.
questions, and then we'll.
Okay.
and then we'll
Okay,
get the-
thank you.
we'll
All right,
fight over the
as quick
answers.
as I can. My name is Ken Brown. I'm the district manager of Bronx Community Board 5, which is a community of about 140,000 people. In August, we opened our first farm stand, the only farm stand in that community. And my secret plan is to try to build effective demand for fresh, good produce. So my ask is, can I get together a consortium of healthcare providers, neighborhood health institutions that are in the district, and get funding for maybe a pilot or maybe a robust program for, I forget what it's called, where doctors prescribe fresh fruit?
Yep.
Yeah.
Thank you. Food is medicine. So we can, on the one hand, build up the farm stand, build effective demand to eventually increase the infrastructure for fresh food delivery, and decrease our rate of 34% obesity in the community. So we'd like some money. We'd like to talk to people about potential funding, get together a meeting with healthcare providers, and get this off the ground.
Yep.
I'll be here tonight.
Hi, I'm Deb Salas Lopez, and I'm the Senior Vice President of Community and Population Health at Northwell Health. It has been a fantastic morning. Thank you. In response to the gentleman who talked about education and wealth, Northwell Health, this is a pilot program, has invested $5 million in creating the Northwell Community Scholars Program for high school students in underserved, economically disadvantaged, minoritized communities, where we're supporting them not only through high school, but also through 2 years of an associate's degree, a technical degree, or certification program to get them into the pipeline of employment. And we are looking, actually, we have some private funders who are supporting. We've now adopted 4 more high schools, 2 in Queens and 2 in Manhattan. Because the earlier we get to our children, they're our future. And the more important it is for them to not only see the opportunities in the world for what they can be, not only clinicians, but anything that Northwell and others could hire for. Employment is wealth, is health. And so I just wanted to respond to your comment because I completely agree with you. Thank you.
Very much.
So I think I want to go back to the question that the first gentleman raised, and very briefly, Kathy, do you want to take that one?
I'll take that one. So I will actually riff off the project that Maggie was talking about in Dorchester earlier. So that project had so the capital stack was about a loan that covered about 75% of the total development costs, and then equity for 25%. Healthy Neighborhood Equity Fund was 90% of that 25% of the capital stack. So I don't have the numbers right in front of me, but say it was a $10 million project. Healthy Neighborhood Equity Fund was 90% of the $2.5 million that they needed for equity. MHIC as a CDFI was also the construction lender on that, and then the permanent lender was our state finance agency, Mass Housing, who also put in what is known as workforce housing. So this is one of those pieces of sort of public funding that really made the project effective. The other thing I will just mention we're doing is, I think Maggie mentioned there's an MBE food business that's in the ground floor. We're trying to work with our Healthy Retail and Commerce Initiative, which we're also partnered with Conservation Law Foundation on, and which BMC was like the seed to make the whole thing flourish and grow, to try to get the commercial unit converted to a condo so that that MBE entrepreneur can own the real estate that her business is located in. Does that? Yeah, was it equity MyTech? No, it was the Healthy Neighborhood Equity Fund. So it was this fund, which is basically made up of about 70% bank and hospital equity, and then 30% top loss capital, which is foundation. Say that again. Yep, sits with the project. It's got a 10-year lifetime. We can extend it for a couple of years if we're in a bad part of the cycle when we need to get out. And then the idea would be a refinance. This developer is very place-based, so wants to keep it in his portfolio. Yep.
All right, well, our time together has gone very quickly, and I know we're almost at time, so I think we're going to wrap it up here, but I think folks will be around if you have other questions. Thank you so much to David and the team for hosting us, and to our panelists for a great conversation today.
Great, thank you. That's a great panel. I'd like to invite Casa Belay to the stage here. Casa joined the Brownsville Partnership as its executive director in June 2022, but he has spent the last 15 years living and working in Brooklyn. His work has spanned youth development, criminal justice, child welfare, and early childhood development, taking him through positions in city government, philanthropy, and community-based organizations. Thank you for joining us, Casa.
Thanks so much. So I'm really excited to be here with you all this morning. Feels like we're getting back to normal with this many people turning out, so that's a great feeling. And I'm just going to share a few stories, or at least start out with a few stories that I think will bring to life what some of these investments that we've heard on the previous two panels are like on the ground in community. So Edith and her husband Antonio are elderly, longtime residents of Brownsville, Brooklyn. They live in the Nehemiah Homes, which is a widely celebrated bastion of homeownership in a community known for having the highest concentration of public housing in the country. The couple suffered from a persistent shortness of breath and shared that they often felt unsafe in their own home, in part because of poor outside lighting, which caused a variety of different issues. They had what Edith called mobile mechanics, or folks that they didn't know, that often set up unofficial shop, loudly fixing cars and congregating right outside of their front porch. And they struggled with high utility bills that cut into tight family financing, which strained basic necessities like grocery shopping. And Edith and Antonio weren't alone. Stefan, a middle-aged Brownsville resident with diabetes, described feeling unsafe when coming home at night as well, and had a tense relationship with his landlord. And Ms. Carroll, another elderly homeowner from the Nehemiah Homes, shared concerns about her bathroom, where she often felt unsteady on the toilet and getting in and out of the bathtub. So these stories underscore a litany of statistics that demonstrate the health and lifestyle challenges that Brownsville faces. And through the work of my organization, which is based in Brownsville, we hear stories like this far too often. When we look at population-level health in Brownsville, we know the asthma emergency department visit rate among children ages 5 to 17 is more than double the citywide rate, and not incidentally, Brownsville has among the highest rankings of chronic absenteeism in New York City. And for adults, the rate of avoidable asthma hospitalizations in the neighborhood is also more than double the borough and citywide rates. And so I know it's no surprise to this audience that there's a strong correlation, even a causal relationship, between one's living environment and health. We spend tens, if not hundreds of thousands of dollars on an individual's healthcare while never really addressing how their home environment impacts their health. Where we live determines the quality of air we breathe, the homes we live in, how safe we feel, kind of foods we can easily access, even the transportation and social networks we do or don't have access to. So in Brownsville, nearly 70% of the renter-occupied homes report having heating breakdowns, cracks, holes, peeling paint, other defects. And 36% of Brownsville households report seeing cockroaches, which we know is a trigger for asthma. Beyond physical health, if you're working to end homelessness or address mental health or offer job training, your work immediately gets easier when your client has a safe and stable home to call their own. So with Edith and Antonio, a few simple home hardware fixes had a dramatic impact on their overall health and safety. Their bathroom was regrouted, its vent was replaced, various holes in the wall where dust was entering were patched up. An energy efficiency check surfaced more quick fixes like installing LED light bulbs and repairing their leaky toilet. And these efficiencies helped reduce their utility bills, which relieved stress on their family finances. And beyond that, the mobile mechanic action, beyond that, we had lighting upgrades inside that helped them cook more comfortably, and better outside lighting increased visibility, which reduced that mobile mechanic action in the front of their homes. And so now Edith and Antonio feel much safer when they're entering and exiting. Their eating habits and social lives changed for the better as their respiratory health and greater mobility improved and allowed them to get to the grocery store and visit friends and family more easily. So these are stories from a housing intervention that my nonprofit, the Brownsville Partnership, has piloted over the last year to improve health outcomes, actually with generous support from Enterprise. But what I really want you to walk away with is not the simple premise that housing impacts health. Instead, I want to highlight the critical ingredient that gets us through the front door to make these home repairs in the first place, which is the trust and credibility. So before I go on, let's identify what too often goes wrong. Breaking down silos. How many of us have featured this concept in grant proposals and best practice recommendations, right? And yet cross-sector efforts like this one at the intersection of health and housing rarely produce referral relationships that are high-functioning and trustworthy. So those silos remain in place. Folks making referrals on the health side typically don't clearly understand what their housing partner is going to do in their patient's home, and the urgency from the health referral rarely feels reciprocated on the housing side. Truth be told, there just isn't much accountability for referrals. In fact, I've heard health practitioners say numerous times that while they absolutely believe in the social determinants of health, they typically won't screen for them unless they trust a process to connect their patients to meaningful resources. So practice, unfortunately, hasn't caught up to the rhetoric of cross-sector collaboration. And I think this is ultimately because there's something glaringly obvious that's missing from that equation. So when the Brownsville Partnership began looking for housing interventions to implement, we sought out efforts with a real evidence base behind them, and we found a model from literally the other side of the world in Australia called Health Habitats. Operating in more than 10,000 Aboriginal households over the past decade, this model has reduced hospital admissions for environmental health-related illnesses by 40% through a really simple home survey and fix model. The key to their approach wasn't just to target home repairs that could improve health and safety, but to make the process as rapid as possible. So they designed a system that began with a survey, a home survey, to surface and high-yield fixes, but began making repairs at the moment that they finished that survey. So let me emphasize this again, because it's really the key to our success. Most models of intervention survey a beneficiary, follow a series of reporting protocols, and then eventually, at some point later down the line, the repairs take place. But in this model, the survey is conducted then right then and there in that exact same first visit, many of the repairs are made immediately. So if we return to Edith and Antonio, the LED light bulb replacements in and outside their home and the patching of holes in the wall where dust was entering, that took place on the very first time our survey team visited their home. You might remember Stefan, who was a diabetic who had a tense relationship with his landlord. He also had faulty lighting and a host of other issues. Stefan's lights and electrical outlets were repaired the day of his first home visit. So when we returned a week later with contractors who were all MWBE certified and local to the Brownsville area, by the way, to tune up his front porch, provide pest remediation, and fix his plumbing issues, he actually believed us and made sure to be available for those appointments. Word had already begun spreading to Miss Carol after we visited her neighbor, Miss Edith. So when we surveyed her home and made appointments to install a higher position toilet and a grab bar in her shower, she kept that appointment too. So remember, these are simple repairs in people's homes, and they led to important lifestyle changes outside their homes too. We had one health coach who referred patients to us who described how an elderly patient of hers who complained of mold and leaky faucets began taking his medication on a more regular schedule after our visit. He even attended his medical appointments with her more consistently because he had this positive experience with her home repair referral, which led him to trust her more generally. The same health coach told me how other patients appeared more easygoing and more readily shared struggles they've been facing. They began elaborating beyond one-word answers and asking about more resources like food pantries because of the trust established by her referral to our organization. Stefan reported feeling more comfortable and confident in job interviews because he could finally take a hot shower again. There's also a direct link between chronic stress and blood sugar levels, so we can infer that even just mitigating that strained relationship with his landlord potentially benefits his diabetic condition. Edith and Antonio were able to more frequently visit the grocery store and cook more often and see friends and family more easily once they felt more secure coming and going from their own home. Miss Carol shared that her elderly sister came for more overnight visits once her elevated toilet and grab bar were installed, which helped her feel more socially connected. So our program is called Community Action for Healthy Homes, and the objective is to improve neighborhood health through this rapid home survey fix process. And the key to our success is not simply the revelation that by fixing housing we can improve health and safety. It is about the speed with which we make repairs. By beginning the repairs the moment we enter the home, we are establishing the trust and the credibility that encourages residents to refer their neighbors and convinces health partners that these referrals are worth making. The more immediately you fix something, the more engaged community members will be. It's the immediacy that drives participation. So feeling safer in front of your own home, being able to bathe securely, to more easily shop and cook for yourself, it restores a sense of independence and social connectedness, as well as one's own confidence and dignity. So in our first year, nearly half of the 133 home repairs visits that we made actually came from referrals from local residents, which I think is a testament to how powerful that element of trust is and how driven that trust is by the speed with which we begin repairing homes. I'm really thrilled to share that in our second year with this program, we're partnering with United Healthcare, the insurance provider, to provide this intervention to their clients in the Brownsville area. And we'll be able to track health outcomes and cost savings at a systems level, alongside a growing referral partnership with One Brooklyn Health System and new ones with New York Presbyterian and their Dalio Center and the New York City Department of Health and Mental Hygiene. So at the Brownsville Partnership, we know we have a lot of work to do to reach our goal of spreading this intervention to the entire neighborhood. And that can feel daunting at times. But I find my motivation in the stories our neighbors tell us when we partner with them. So I'll close with what Edith pointed to when I asked her what made this work. She told me, not only did I feel comfortable letting you all into my home, but remember, this was the pandemic. So the trust was really important in order for me to recommend you all to my neighbors. So just imagine what we can accomplish when the momentum of the word-of-mouth referrals combines with a strong network of referrals from insurance providers and hospital systems to serve Brownsville at scale.
Thank you, Casa. Thank you for closing out on a positive note. I mean, the conversation was really rich. I enjoyed it quite immensely. A couple of things struck me about the conversation. I was taking a couple of notes, too many to go through here, but a couple of things struck me. We're trying to create this ecosystem for children to succeed, and I think we're getting there. We're close. And when I was listening to Bashara and Chris and David talk about how those conversations first started 10 years ago, looking back, that was movement, that was progress. But in the moment, you're not thinking that you're going to get somewhere. You're just having these strategic conversations. And 10 years later, you have an investment strategy and you're investing money and you have money on the street. That is amazing. And so I think when we look back years from now, and we look back today and we see where we are, we'll realize that we were further along than we thought where we are today. And so these partnerships, these conversations are really important, and we're so happy to be able to host these conversations here. I hope that you'll be able to take advantage of the reception. I call it a reception because for me it's like this is super exciting to have everyone here together afterward and have conversations and continue this conversation and let us know like what's the next step. What should we be doing? Where should we be? Who's missing? Actually, who's missing here, right, at this part of this conversation? We have a lot of key folks here, but we know that we want to expand this tent because we want to expand this way of thinking that health and the economy go together. And that conversation is a broad tent. So thank you all. Thank you for everyone who traveled here. And we look forward to continuing the conversation. Thank you.